We already described the pressure ulcer. We know the stages of the pressure ulcer and how we can describe these pressure ulcer. However, there is possibilities that we will have a misdiagnosis or misunderstanding with other skin injuries that looks like similar to the pressure ulcer, or at least it happening on the same patients with the same risks. Here, when we are discussing about incontinence-associated dermatitis, what is the incontinence-associated dermatitis and how we can differentiate incontinence-associated dermatitis rather than the pressure ulcer? And does it make any difference if we just treat both of them on the same way? How much the differences between these two diagnoses, pressure ulcer and incontinence-associated dermatitis, can enhance our choosing for a proper treatment. This is Abdelkarim Blasi and welcome to our training, Pressure Ulcer from A to Z.
Skin alterations, redness happening in the perianal area or genitalial area, and this already happening with the same patient. High risk to develop pressure ulcer, but it had a little bit of differences that it's much more wide, red and superficial, irritating, and it's making a pain for the patient. Then we are talking here about incontinence-associated dermatitis, IAD. Stay with us. Assalamu alaikum, this is Abdelkarim Blasi, and we are continuing now for skin disorders that already related to the pressure ulcer can happen with the same patient on the same condition, but there are some tricks here and there, and we are looking now to clarify these tricks. This week we'll go over some ulcer or wounds that can be confusing, as these skin injuries could look like pressure ulcer, but in fact they are not pressure ulcer or not pressure injury. So what's the similarities and differences in these sessions? We will start with the incontinence-associated dermatitis. Incontinence-associated dermatitis described as the skin damage associated with the exposure to urine or stool. It causes considerable discomfort and it can be difficult to heal. Also, it's a time-consuming, expensive to treat. The main challenge in incontinence-associated dermatitis is the wide range of terms that used to describe the skin injury. For example, there are many text box or references. They still used napkin, nappy dermatitis, rashes, dinapkin rashes, nappy rashes, irritant dermatitis, Moshi region dermatitis, perianal rash, and all of these terms just only describe the same skin condition, and this making a confusion among the clinicians. As you can see here, these are the high-risk anatomical area for developing this condition, incontinence-associated dermatitis. And it's already classified over 14 regions, and all of these regions are in risk to be exposed for urine or stool. And these are the skin injuries related to the contamination with the stool and urine, or maybe both on the same time. Before we talk about development of incontinence-associated dermatitis, we should know the physiological function of the skin and the anatomy of the skin layers that are the main barrier of the skin. A revision for what we described on the first week. The outermost layer is the sternum corneum. If you remember from the first presentation and the first week about the anatomy of the skin, we described that epithelial layers contains of 5 layers. The sternum corneum is the outer layer, which is turn and crook depends on the skin. It consists of 15 to 20 layers. These cell layers called corneocytes. 19 of these layers are formed from keratinocytes. Sternum corneum is consistently renewed as the upper cell layers are shed more cells comes up from the lower layer to maintain the sternum corneum thickness, to maintain the skin integrity. This is the dynamics in this layer of the skin. The corneocyte layers are embedded in the lipids in the pattern that they has linked to the springs and motor on a wall already make this protection. The corneocytes are also joined to each other by protein, and this protein between the cells known as desmosomes. These links called desmosomes that connect these cells to each other. The whole structure is important in regulating water movement out the sternum corneum. Then in this way it keeps ensuring and sufficient assuring hydration, sufficient hydration for effective skin function, and it prevent overhydrating over this layer. Corneocytes contain a variety of protein, sugars, and other substances that together known as the natural moisturizing factor. Natural moisturizing factor, it's known as NMF. The NMF helps to hydrate the whole structure to maintain an effective and flexible barrier. As you can see, there is a picture of the referral to the nature of corneocytes and what are the relations of these layers, and in the vertical, horizontal, and also from down to up, or what is the NMF already create. The second item here I want to also to stress on is the pH of the skin. pH is an indication for the acidity level. The skin acidity, it's located in a part from 4 to 6 over of the pH level. As you know, the pH, it's the neutral side 7. When you go down, it's acid. When you go up, it's base. That means the skin is much more close to be in acid part, not so much acid, near to be in the higher acidity format from 4 to 6. Apart from this role, it's maintaining the acidity and assist regulating the bacterial colonies and what's known as the skin normal flora. The body in need for this normal flora already is there, but we are not looking to have it in much more exceeding, or we don't like it to be exceeding our abilities to accommodate as normal skin. That's why it should be stay among this level. The skin is already in acid part. It's coming from higher level of acidity from 4 to 6. Normal flora supporting the skin, supporting us in maintaining this level. Whether in incontinence situation, when the skin already getting in a direct contact with the urine or stool, the moisture will be increased. Urine is water and the stool already contain a high humidity. And this moisture is accumulated between the corneocytes, and this leads to overhydration, which will cause swelling and destruction of the structure of the sternum corneum and leads to visual changes in the skin, which known as maceration. This maceration, as a result of excessive hydration, it will lead to damage on the sternum corneum, and this will increase the risk of injury from friction as this layer start now to be disappeared. And this will make much more effect of any injuries coming from the skin, the clothes of the patient, or the bed linen of the patient. With exposure to urine and feces, the skin pH will be changing. Now the stool is much more alkaline in the base, and this will make the pH of the skin shifted to alkaline part. And this will make the skin much more weak and accessible for further contamination and injuries. pH into alkaline media will allow harmful microorganisms to host the skin and increase the risk of infection, as well as change the nature of the skin. Also, the feces, the stool already contain prolytic enzymes, and these enzymes will be responsible to destroy the protein of the skin, of the corneum sternum, and even destroy the protein links that connect the cells to each other. And this will make these cells are alone, independent, and unable to provide its function by making the layers of the protection for the body. And the changes coming from the alkaline by its nature of the stool as a high alkaline, this will make the enzymes come from the stool much more active to destroy. When it's come in contact with the skin, this will increase the ability of this enzyme to destroy the relations and destroy the cells, and this will make us losing or make the patient lose the sternum corneum and much more risk for having the incontinence-associated dermatitis. As you can see here from the diagram, all of this will reduce of the skin integrity and will increase the risk of developing incontinence-associated dermatitis. It will start by the urine, then the feces, then it will be much more hard when already both of these two items getting direct exposure to the skin. This picture will explain this picture explain what's going on inside the skin layer. This is taken from the incontinence-associated dermatitis guideline, and that shown the efforts of combination of the chemical and biological irritation as well as the pressure and shear will lead to the skin damage. In order dealing with these injuries, we need to create pathway to proper assessing the skin in this condition and proper providing a description about the condition or what's going on. The purpose of this clip just only explain the incontinence-associated dermatitis. Explaining the pathophysiological changes happen over of the skin, it will lead us here to support or prescribing or going for the proper treatment. We already described the incontinence-associated dermatitis. We discussed what's going on in this condition. There are so many patients that make these two events happen for the same patient, incontinence-associated dermatitis and pressure injury. We already observed in the hospitals that nurses getting confused in defining these two injuries, which are totally different from each other. And for the same patients both, that we will have incontinence-associated dermatitis and pressure ulcer. However, our objective on this level, it's just only to define the problem, and this is what we will have in the second part of this course. This is Abdul Karim Blasi. Stay with us and be safe. Thank you very much.